All right, let's play detective. You've got a patient, they've got serious spinal symptoms. And the MRI, well, it shows a lesion. And that lesion could be anything. This is a real mystery. And to crack the case, we have to start with the single most important clue there is. Location. I'm telling you, if you can figure out where it is, you are well on your way to figuring out what it is. So here's our game plan. First, we'll map out the 3 main neighborhoods of the spine. Simple. Then, we'll look at the usual suspects you find inside the cord, then around it, and then even outside its main protective layer. We're also going to expose some imposters, things that look like tumors but aren't, and we'll wrap it all up with a rapid-fire round of classic radiological signs. Okay, so you're looking at the scan, you see that spot. And the list of things it could be is a mile long. It can feel pretty overwhelming, right? But here's the secret. For just a second, forget about what it is. Focus completely on where it is. In spinal imaging, I'm telling you, location is absolutely everything. So let's start right there with that critical first step. We're going to divide the spine into 3 very distinct anatomical neighborhoods. Seriously, just getting this one concept down will slash your list of possibilities and get you pointed in the right direction. Here's our map. The spinal cord is wrapped in this tough, protective sleeve called the dura, so anything intramedullary is growing from the cord tissue itself. Easy enough. Anything extramedullary intradural is outside the cord but still inside that dural sac, just kind of hanging out in the spinal fluid. And finally, extradural means it's outside that sac entirely, usually coming from the bone or other tissues. Every single lesion has to live in one of these 3 places. Let's start our investigation in the first neighborhood, the intramedullary space. When a lesion is growing right from inside the spinal cord, our list of prime suspects gets really short, really fast. Our 2 main culprits in here are ependymomas and astrocytomas, and the key is knowing the profile. If your patient is an adult, your brain should immediately go to ependymoma. It's the most common one in that group, by far. You'll be looking for something right in the center of the cord that lights up nice and evenly. But if you're looking at a child scan, the odds flip to astrocytoma. These tend to be off-center and light up in a really patchy, messy way. Here's a great way to tell them apart. Think of an ependymoma's enhancement like flipping on a light bulb. It's clean, solid, and bright all over. An astrocytoma, on the other hand, well, it's more like a messy fingerprint. The enhancement is all smudgy and irregular. Honestly, that simple analogy can be the clue that cracks the case. All right, time to move our investigation. We're now in the second neighborhood, the extramedullary intradural space. So we're looking for things that are outside the cord but still inside that protective dural sac. In this space, the usual suspects are nerve sheath tumors, and suspect number 1 is the schwannoma. It grows from a nerve root, but it doesn't really swallow it. Its close cousin, the neurofibroma, does swallow the nerve root, and it's a huge red flag for neurofibromatosis type 1. But the neurofibroma often leaves behind a very specific calling card. And that clue is the target sign. On a T2 image where fluid is bright, this thing looks just like a bullseye. You get a bright outer ring with a dark spot in the middle. Finding this is like finding the suspect's business card at the crime scene. It points right at neurofibroma. Our investigation now moves to the third and final location, the extradural space. So here, we're looking at stuff that's coming from the vertebrae themselves, the discs, and all the tissues outside of that main dural lining. 3 common players out here have really distinct looks. A vertebral hemangioma. The most common benign tumor you'll see here is often bright on both T1 and T2 and has this classic jail bar or corduroy pattern. An aneurysmal bone cyst is much more aggressive, looks like it's literally blowing up the bone, and you'll see these different fluid levels inside it. And then there's the osteoid osteoma. It's subtle, just a little bright dot, the nidus, surrounded by a bunch of thick, dark bone, usually hiding in the back of the vertebra. So up till now, we've been hunting tumors. But sometimes the thing causing all the trouble isn't a tumor at all. It's a great imposter, a vascular problem, or an inflammatory process in disguise. This, my friends, is where the case can get really interesting. Let's start with the vascular impersonators. The most important thing to know is that one type completely dominates the others. A whopping 85% of all spinal AVFs are type 1 dural AVFs. This isn't something you're born with, it's something people get when they're older, usually in the thoracic spine. That makes it your number 1 vascular suspect to rule out every time. And we can break these down by location, just like we did with the tumors. Type 1, the big one, is dural. Type 2 is different. It's intramedullary, a tangled nest of vessels right inside the cord.
and it's often tied to syndromes like HHT or Klippel-Trenaunay. Types 3 and 4 are rarer. The key takeaway here is that location helps you sort these out, but an angiogram is really the only way to be 100% sure.
Now for the inflammatory imposters. The classic showdown is multiple sclerosis versus transverse myelitis. Just think of them as opposites. An MS plaque is short and partial. It covers less than 2 vertebral bodies and only affects a piece of the cord. Transverse myelitis is long and full. It spans more than 2 segments, takes up most of the cord, and causes a ton of swelling that can absolutely mimic a tumor. Now look at this. You see this inverted V of bright signal in the back of the cord? This pattern can be from 2 totally different things, vitamin B12 deficiency or HIV. On the MRI, they can look identical. This is a perfect example of why we treat patients, not pictures. You cannot solve this puzzle without the clinical history. It's impossible.
Arachnoiditis is just nasty scarring, usually after a surgery or an infection, and it glues the nerve roots together. It can show up in 2 opposite ways, which is kind of wild. You might see the empty thecal sac sign, where all the nerves are basically plastered to the walls of the dura. Or you could see the exact reverse. All the nerve roots get pulled into a single tangled mess right in the middle. Another inflammatory issue that messes with the nerve roots is CIDP. Think of it as the chronic version of Guillain-Barré syndrome. And its appearance, it's unforgettable. Like the slide says, the buzzword to remember is onion bulb nerve roots. They get thick and they enhance in these concentric layers, creating this really classic look. All right, let's wrap this thing up with a rapid-fire round. We're going to look at a few classic signs and see how a single clue can point to a whole bunch of different culprits. It's a great reminder to always think about the whole picture. So take the owl's eye sign. You see these 2 bright dots in the front of the cord. It's famous for being a sign of a spinal cord stroke or ischemia. But look at this list of other things it could be. This is the perfect illustration of why a radiological sign is a clue, not the final answer. You always need the full context. Next up, a syrinx. It's basically just a fluid-filled cavity inside the cord. Now, if you want to be super technical, a hydromyelia is when the normal little central canal just gets bigger. A syringomyelia is a totally new cavity that forms somewhere else in the cord, without that normal cell lining. But here's the punchline. While that technical difference is, interesting for textbooks, it makes 0 clinical difference to the patient or their treatment. None. And that's why in the real world, everybody just says syrinx. It's a great reminder that our goal as spine detectives isn't just to put a name on a finding, but to use that finding's location to narrow down the suspects and get to the right diagnosis for our patient.